Okay. Okay, everyone. Unfortunately, whatever the problem is, it isn't fixed. But we are able to record the meeting. So although we won't be in the position where people externally can be watching what we're doing live, at least they will be able to access it later. So we are going to make a start because you're already getting overheated. I can see the number of very attractive fans and makeshift fans expanding at a rate of knots. So my name's Sue Davis, and I have the great honour to chair the board and to have done that role now for 7.5 years. Extraordinarily, the time seems to have absolutely flown by. So this is my 8th annual general meeting in this room, and it is great, as ever, to see the room full. So my first thanks are to all of you for coming, for having enough interest in what we're doing and wanting to hear about what the Trust has done in the last year. It's really good to see you. I have 1 or 2 apologies for absence to record. Our Vice Chair, Joy Warmington, isn't able to be with us. Our Head of Psychologies, Amanda Gatherer, is at a funeral, so she's not able to be here. Is there anyone else who's asked you to record that they couldn't be here even though they wanted to? Oh, Hilary Grant, our Medical Director. Okay. Is she... Oh, she's on. Oh, is it her daughter's graduation? Aha! I think that's a really good excuse. 1 or 2 introductory comments from me, and then my executive colleagues will give you a feel for what's happened in the Trust, or what did happen in the Trust, 2018 to 2019. But having done 1 or 2 apologies for absence, the first thing I want to do is do 1 or 2 welcomes to folk who weren't here last year. After a period in which the board itself was fairly stable and very few changes happened, in the last 12 months we've had 4 changes in the board and a change in company secretary. So our thanks will go to Dr. Nerys Williams, who completed 7 years as a non-executive director last December. And our welcome to Linda Cullen. I'm going to ask Linda to stand up and wave, who joined us in January as our new non-executive director with clinical experience. Linda's a psychiatrist, so it's really good to have her input to the board. You will all, I think, probably know that our Chief Executive, John Short, retired at the end of March. Our new Chief Executive, Roisin Fallon-Williams, will be speaking to you later, so I won't ask her to stand up now, but she will later. So it's very good to have Roisin with us. And then our Deputy Chief Executive, Brendan Hayes, was successful in being appointed as Chief Executive of the Lincolnshire Partnership, and left us at the end of April. So we had a series of board meetings at which we were saying goodbye to people for all of the right reasons. And Brendan is thriving in Lincolnshire. I saw him last week and asked to be remembered to everyone here. And we have Vanessa Devlin. Where's Vanessa? Vanessa is interim Director of Operations. We will be appointing substantively to that role later in the summer. And then a post that hasn't yet filled, our non-executive director, Barry Henley, this is another good news story, left us because he was appointed as the chair of the board at Birmingham Community Trust. So we think it's excellent that we have someone who knows this organisation so well, working with an organisation that's such an important partner. And we're at the moment advertising for someone to replace Barry. So if anyone in the room knows of anyone with a private sector background who might be interested in a non-executive role, you've still got a few days to apply. And then finally, our company secretary, Barbara Anthony, left us for a role in governance at Sandwell and West Birmingham hospitals, and we've been delighted to be joined by Sharon Madeley, who was at the back somewhere before. I've lost her, there she is. So Sharon's at the back, who did a similar role I'm going to get this wrong and embarrass myself. Was it Kettering? Kettering, it was right. So, Sharon's been with us a couple of months. So if any of you want to have a word with those new people at the end, do please do that. And then I'm going to ask the rest of the members of the board who are here to stand up. So we've got Wahid and Janjit, non-executive directors, and Russell at the back. Can everybody give a wave? So three non-execs here. And then Charlotte. Where's Charlotte? Charlotte. Yes, sorry. So Charlotte Bailey, who's our Director of Strategic Partnership, she's not giving a presentation. Any of those people might be asked to answer a question later. And we've got our wonderful governors, but I'm not going to ask them to stand up now because there's a whole section on what they've been doing later in the presentation. So what my executive colleagues are going to be talking about in their presentations in just a little while is principally about our performance as a trust. So it's inward-looking as well as being mostly backward-looking at what we did last year. I'd just like to kick us off by thinking about what are the external pressures and changes that are also making a difference to the way that we work, because we don't work in a vacuum, we never have. There are some very significant changes happening in the NHS, which are really quite significant for us. And I'm going to start by just saying something about the way we're regulated. You will be hearing about CQC inspections in the presentations that you'll hear, particularly from Sue. But the CQC, as the quality regulator, has recognised that really it struggles to have the capacity to do whole organisation inspections on a very regular basis. So it is now looking at doing things far more selectively, doing things at possibly longer time intervals, looking at particular divisions and using the information they have from other organisations about our performance to judge when they come to see us. And that's raising a whole question mark about what the value then of a whole organisation rating will be. So there's quite a lot of conversation happening nationally about how the way the CQC inspects will change the way we're able to report on our services. And they are also, at the CQC, looking at how they regulate partnership. And that's something they've not worked out yet, but it's hugely important to us because we are increasingly working with other organisations and having to think about how our responsibility impacts on their quality and vice versa. So we're watching very carefully to see what the CQC will have to say about how it will regulate the provider collaboratives that we are now operating in secure services, and how it will regulate the partnerships we build up across the STP, that's the Birmingham and Solihull system. And then our regulation of our performance and our finances is also, I think, changing. So at the moment, we have a regulator called NHS Improvement. If you look in the legislation, you won't find it because it's been constructed since the regulation was set out. But NHS Improvement is now increasingly working with NHS England, the old NHS, and it's difficult to see sometimes where the join is between the people who commission our work and the people who regulate it. And they are now working together on a pan-regional basis, and they are taking a much more controlling interest in the work of individual trusts. So I know Dave Tomlinson, our Director of Finance, will be saying something later about us being, I'm not sure what his phrase is, master in our own house. But it increasingly feels as though, although we're a foundation trust, we're being deprived of some of the controls that we used to take for granted. So NHS Improvement is taking, for instance, a much greater interest in appointments to boards of trusts. They tried to invite themselves. When we appointed Roisin, they invited themselves to join the interview panel, and I politely declined their invitation. But they are, we were clearly capable of making our own decisions, but they are increasingly taking an interest in appointments to boards, and are certainly taking a much greater interest, very direct interest, in the way we spend our money. And we've seen that this year in discussions about how much we are allowed to spend on capital, which until now, as a foundation trust, has really been in our own hands, if we had the funds. And then At a regional level, we have the Birmingham and Solihull Strategic Partnership. And that we are enthusiastic members of. But the more we work in partnership with other organisations, the more we have to be prepared to give up a little bit of control over the way we work ourselves. And that poses a real question for us as a board, and for all boards in thinking about their primary responsibility to their organisation. And our governors have been very supportive of us in saying we should be thinking about the whole system and thinking about how we collaborate with our partner organisations in the NHS, in local government, and in the voluntary and third sector. But that does impact on the way that we work as a board and therefore as an individual organisation. And we're sometimes then impacted by decisions that others make. And so one particular quirk is that although there is something called the Birmingham and Solihull, STP, it doesn't cover all of Birmingham. There's a Sandwell and West Birmingham STP, which is responsible for the part of Birmingham that is covered by City Hospital. And everyone in Birmingham has agreed actually that ought to be part of what we're working on, but the decision on that was made by the GPs in that area who decided to stay as they are. So there are lots of things that happen where decisions are made by other folk and other organisations that impact on the way we work. And it's important, I think, to state that at the start because, as I say, we don't work in a vacuum. And all of those things are things the board has to think about and the board has to work around. Nothing stands still. So constant vigilance was somebody's watchword at some point. But actually going back to the point that I made at the start in terms of the changes on the board, constant refreshment of the board itself is actually a welcome addition in allowing us to think about the new situations we find ourselves in and the new world in which we have to work. That's an external, possibly forward-thinking look. Now we are going to move to the formal business of the AGM. So we've got to start with the minutes of the last AGM. This always feels slightly strange because it's a year ago and a lot of folk who were here weren't there then. As far as I can see, they're an accurate record of what happened. Is everyone who was here, who was there, happy that they are accurate? Everyone happy we can accept them? Good. So then I will hand over to my executive colleagues and first of all to Roisin Fallon-Williams to talk about last year. Roisin.
Thank you, Sue. Good afternoon, everybody. What a privilege for me in the role for 2.5 months to stand before you and talk about what an amazing organisation you are all part of, that you support. And I make no apologies for the fact that the majority of what I'm going to talk about today is about celebrating what we do well. I was involved in one of the sessions earlier about quality improvement and in asking the people that took part what were some of the things that we could do to improve things. They talked about that actually we should do more, shouting from the rooftops about some of the fantastic things that go on in the organisation. So today is partly about that. So a little bit about our performance. You may or may not know, and I think I saw one of our commissioners, I saw Joe there earlier. Hi, Joe. May or may not know that we have hundreds of performance indicators that give us traction about what we're doing well and not so well. And I'm not going to go through all of those, but suffice to say that we do well on most. There are, for the majority of the time, we perform well. There are a few that we need to improve on. But those that we really excelled at this year are the 3 that are up on this slide. So it exceeded our waiting times targets, particularly for psychological therapies. First episode psychosis and eating disorders for children and young people. And that was no easy task because those targets are really very high. They're very stretching. And every year I think staff feel, we're not going to do it this year. But they exceeded them this year. So I think everyone's to be congratulated for that. Our National Community Patient Survey said that more service users know who to contact in a crisis and where to get help when they need to get it. And as we all know, that's really important, that we know where to go when we need it. We don't need things all of the time, but the times that we do need it, we need to know how to get there. And our patient-led assessments of care in our environments, our place assessments, I think we should be really proud of the fact that we're in the very top echelons of achievements within those. And they're not something that we make assessments of by ourselves. Many of you in the room will have helped us determine how those assessments have come out. And I think we can be really proud because that's actually something we provide in partnership. We achieve that through working with our partners, not just through doing that as an organisation. In terms of new services, we have a number of new services that came on stream during this year. And there are 4 of those in particular that are mentioned here. I don't want to go into too much detail about them. You'll know more about them, many of you, than I will. But our Youth First, a very important service to young people. Our Veterans Service, which came into existence towards the end of last year and has just, in fact, been agreed to be extended somewhat because this is a really valuable and much needed service. We've also won new contracts for our Recovery Near You and our Solihull integrated addiction services, which are aimed at people who have addictions and need our support. Other new developments that have been less about contractual arrangements, but have been about some of the more innovative things and the more developmental things we want to do in the organisation. Again, just 3 to highlight here. But predictive analytics, who knows what that means? 1 or 2 people. What I hope for, and one person in particular who works really hard on this, I can see, what I hope is that going forward, we'll all learn a lot more about what technology and diagnostics like this can help us do to really think differently about how we provide services and whom to in what order. So this particular piece of work has been undertaken with 4 community teams, and it's designed to help us understand through looking at our data and looking at the information that's available to us, designed for us to predict in advance which people we're working with right now who are most likely to require crisis intervention in the next 28 days. So it's really exciting work that will really support clinicians to really determine how they prioritise and how we give best services to those of you that need them most at any time. The digital ward app doesn't sound very exciting, does it? But what it does mean is that by having that actually staff's time is freed up much more to have face-to-face contact with people whilst they're inpatients, and it does away with the idea that actually paperwork is being filled out after the event, so it's real-time capturing of information on the wards. And then thirdly, about the Maple Centre, which is a much-needed community hub in the Solihull area where there's been a significant amount of investment. Sue talked about our ability to raise capital and use our capital, use some of our what little resources we do have to develop new things. And this is one of the things that we committed to last year and will come into fruition and be available to everybody pretty soon. Sue has already mentioned working in partnership. I don't want to dwell too much on these very specific things on this slide, but much more to say we achieve very little of any significance on our own. So partnership working is really vital to us. We understand that actually it's really vital to you too in terms of needing to work differently to support you and with our communities. And these are 3 examples of where we're working very differently, sometimes across boundaries that we would never have worked across before. So we might have been in competition with organisations that we now work with very collaboratively for the best interests of the people that we're here to serve and that rely on us to be here. So partnership isn't just about other organisations that we work with. Partnership is about how we work together with those of you that we provide services to, with those of you that come into contact with us because you're a carer of someone who receives services from us, and those of you that work in the organisation, of which there are over 4,000 of us. Oops. So Recovery for All was launched here in the Trust in 2016, has been looked at with interest by many of our partners and adopted as a consequence of the fact that it was introduced here at that time. It was extended during 2017 into Solihull, and during this latter year, we've extended it into North Birmingham. And it's really about recovery for all. It's about supporting people to be the best that they can be. It's about supporting people to have hope through having support and connectivity and a peer group with whom to share time and to learn new skills and develop new opportunities. And during this year, nearly 1,000 people have taken part in the sessions that have been run by the recovery colleges. We've run a number of community engagement seminars on a number of different subjects, but particularly focusing on working with communities that we feel we need to do much more work with around enabling people to understand better about what mental health well-being can mean to them, but also what mental ill health can mean to them and how we can support them. Engaging with our staff remains a real clear priority, and during the last year we've introduced a number of things that you told us would be helpful to you. So our staff health and wellbeing app and our website was launched because actually everyone's well-being in this organisation is important, and a clear way for us to support that is through using technology to help us make clear to people what's available to them. Our Dragons supported 18 new innovative projects, and our staff networks went from strength to strength. And I hope some of you will have taken the opportunity to both talk to our people in the Recovery College and our staff networks. And our staff networks have been really crucial in helping us think differently about what inclusion could look like and how real integration can happen in the organisation, not just for staff, but the impact of that is it has an impact for people that we serve too. So lots of things have happened during this year, and I've only picked a few to highlight. But I also want to look forward. I want us to think about what's going to be coming in the coming year. And this is probably slightly safer territory for me, only having been here for a matter of a couple of months. But just want to remind everybody about why we're all here. So it doesn't matter if you're one of the 4,000 staff in the organisation, it doesn't matter what job you have that you do. If you're somebody that's a volunteer, you're a carer that supports us, you're a service user by experience, we're all here for the same reason. And that is to improve mental health well-being by making a positive difference to people's lives, with an emphasis on the positive, at a time when people may not be feeling their most positive. As I said earlier, we don't do that by working alone. And at the heart of what we do is about working with people, working together, and our staff having really great contact with people on a day-to-day basis. A very important aspect for us. What we ask of everybody who works within the organisation, all 4,000 of us, is that we live, breathe, act our values, that we behave our values. And there are only 4 of them, but they're very, very important. They're what brought us to this organisation. It's certainly what brought me to this organisation, the fact that these values existed, because they resonated with my own. The fact that we want to be open and honest, and if I'm being open and honest, I'm not sure that we always are, that we are sometimes more likely to be defensive. And that is something that we absolutely strive to want to do something about in terms of being much more open and honest, because it's one of our key values. Our second value is about compassion. And what I've seen in the short time I've been here, so I've been out and worked and shadowed with some members of staff, I've seen absolute compassion in the delivery of services. What I'm wondering is how compassionate we are with each other. And I'm keen that we ensure that that value resonates for everybody in the organisation, not just for those who receive services. Our third value is about respect and dignity. And again, what I've seen, what I've heard, is that for the most part, that is how we behave, and that is how people experience us. But equally, I've heard stories about people about how we aren't as inclusive as we should be, the integration of people from all the different people that make up our organisation and that are party to our organisation could be much better. And so going forward, I'd like us to really think clearly about how we improve on being more inclusive and how we be much more integrative as we go forward. And our fourth value is about commitment. And I haven't seen anybody or met anybody yet in this organisation who works with us or for us who isn't absolutely committed to our vision and isn't absolutely committed to wanting to improve what we do today, to make sure that actually what we do tomorrow is still valuable and still valid and still hits the mark for people. So I think I've touched a little bit on some of our challenges when I talked about the values. And equally, I think that's borne out in our CQC report. Everyone will be aware that we were disappointed that we received requires improvement. And yet, when we read the report, I think there were elements of it that really resonated with us around where we could do better. And of course, our commitment is that we want and absolutely want to do better. So for us, that's about how are we going to think differently? How are we going to think differently about the demands that are upon us at a time when capacity remains the same, demand is absolutely increasing? How are we going to think differently about creating under pressure that real compassion for each other, regardless of how much stress and pressure that we're under? And how are we going to think differently about every voice matters? Everybody's perspective is of value. And can you still hear me? Everyone's perspective is of value, and how do we capture the whole wealth of ideas for improvement, for doing things differently that you all have to offer us? And so what does that mean for our priorities? So we've done quite a little bit of work in recent months to think about how do we really focus in on 3 or 4 things that we will all get behind and all focus on because they will make the biggest difference for us. And I just wanted to share what those were with you. So having a really keen eye for quality and safety and making sure that we continually improve quality and keep services really safe is one. Culture, our culture and our people. And that means everybody, and it reflects a little bit on what I've already said about how do we make sure we are as inclusive as we can be? How do we make sure that everyone's voice matters, everyone's voice is attended to? The demand that we currently are under at a time, as I said, capacities staying pretty steady is a significant issue, and our attention to that should not just be about, well, we need more of something, because even if we had more of something, we also know that actually we've got a significant issue with the workforce at the moment, in terms of the workforce coming through the pipeline. So we really need to think about how do we use the current resources we've got in the best possible way? How do we transform how we work differently, think differently about who provides what, in what place, to whom, that can help us really think about tackling demand and capacity. And if we tackle that, then sustainability is something that we can truly say we're on the road to establishing, because sustainability is about making sure that there are services still here in 5 years' time, in 10 years' time, that are fit for purpose and that are available to people when they need them. And finally, I just wanted to say thank you. I know Sue has already said some thank yous. I want to say thank you for the fantastic warm welcome that people have given me in my arrival here. I want to say thank you for your openness and your honesty. People have been very honest with me about what it's like to be here, both from a good and not so good perspective. I want to say thank you for the compassion that you show every single day. Thank you for the respect that you've shown me, and I know that you show everyone else every day. But more importantly, thank you for your commitment. In the room, we have people who work in the organisation, people who work with us because they have received services from us and they want to give something back. We have people in the room who are carers of people who receive services from us, and we have people in the room who are experts by experience and people who commission our services, people who we work with in partnership. Without all of you, without all of us working together, we would not be in a situation where we can make any difference whatsoever. So thank you very much. Okay, so I'm going to leave you with a film before we go on to Sue. So this film depicts for us the kind of organisation we want to be. This is what we would aspire to be. It's a film that's not set in a very mental health orientated, well, not in a mental health orientated setting whatsoever. But I hope that when you watch it, you will know what I mean when I say this is what we strive to be, and that you will be able to see the connection between what's happening on the film and how it could be for us going forward.
Thank you. Doesn't really need any words to follow that. But I ask you to look around the room and know that everybody in this room has a story just from today, maybe from the last week, last 6 months, 12 months, 12 years, 20 years. And as Rasheen says, this is what we aspire to. And I am proud to say, as Sue Hartley, the Director of Nursing of this organisation for the last 5 years, I have often seen that, but not always. So I think this is probably the most important message that we take home from today. So thank you, Rasheen, for your words. And as I say, this takes us into the piece of the AGM that talks about the quality that we deliver every day for service users and carers. And I'm going to be ably assisted, you'll be glad to know, through my presentation, rather than just hearing me for the next few minutes. I just wanted to say, really, in the first instance, that I do see this regularly, quality being delivered every single day. And I wanted just to share a very short story of something I saw not long ago when I was out with one of our community teams. And as I say, this is not exceptional to one person or one team, but it is a story where somebody went over and above to deliver quality of care to a service user of ours, where actually in a busy day she could have easily not taken accountability. So in one of our community teams, a CPN is looking after a gentleman that's been known to her for many years and she has a good relationship with. And we're out on shift and she receives an emergency call from another agency that's with this gentleman to explain that this man is acting more unusually than he usually presents, in quite a distressing way, but that this agency worker was unable to stay with this gentleman in the flats where he was roaming around and had left him, but had called our staff member because he knew that she had a good relationship. This staff member, who had got care plans to update, other service users to see, team meetings to go to, diverted her attention, and we went to see if we could find the gentleman. We arrived at his flat door where the door was shut, and it was clear that there had been some kind of commotion outside the door before he had gone back in. She knocked on the door because we didn't have access to it, and we couldn't hear anything. And she persisted. And we heard grumbling from behind the door, and she was immediately clear that this gentleman was very unwell. It was not his clear presentation at all. So she rightly called the ambulance and the police to gain access. And in this time, this gentleman, after about 15 minutes, came to the door and opened it and let us in. And I can tell you, as a registered general nurse of 30 plus years, I took one look at this gentleman and absolutely could see that he was not well. And through the values of this organisation, the nurse supported this gentleman compassionately. She absolutely managed his dignity and respect with myself and other agencies who attended to ensure that he was at the centre of his journey and that she was committed to him. And she was really open and honest. He's not a gentleman that would have found going to hospital easy or a first choice, and he was really, really unwell. And the outcome of this is that this gentleman is now well back in the community and able to continue his journey of recovery. But what is remarkable is that this man also recovered sepsis. And for those of you that understand the diagnosis of sepsis and not intervening within a time what the outcome could have been, actually her actions saved that gentleman's life that day. And that's what I see in this organisation. I think it's really important that we think about what our colleagues do every single day. So the nurse I'm talking about knows who she is, and that team, and to all of you, thank you. I see it in all of our teams every day. So what do we mean by quality? So I've given you a story where I think that's delivering quality right the way through, over and beyond everything that she does with the relationship with the gentleman around his mental health. But we break it up into 3 areas. We say we strive to provide safe care, we strive to provide an excellent service user experience, and something that's clinically effective. And this is a slide that we use in our trust induction every fortnight, and I think it's one that I certainly focus on over a lot of time. Because I think for any members of public, or if we are going into any healthcare organisation, we have an expectation that things will be safe. And they aren't always, and we might pick up a little bit about that later, but we expect it to be predominantly safe. We expect the treatments and the range of treatments to be offered to her will be the most clinical effective, that there'll be nice guidance, that they will be the most evidence-based. And we expect our experience to be excellent. And I restate that sometimes when we have lessons to learn, when we make mistakes, when maybe safety hasn't been maintained, or maybe outcomes have been slightly compromised, people will work with us if we've given them excellent care, their excellent experience, if we've listened to them openly and honestly. And that's how we break down quality. And as Rasheen has already mentioned, I beg your pardon, we deliver those through our values. So our quality account culminates in a large report, and there is a link on the slides here to our website where you'll be able to read the full length of the document. But in a really short nutshell, it just really gives our commitment to what we're trying to do on quality, how we're trying to improve delivery, and how you and the system and our public can hold us to account to say, are we doing what we said we were going to do or not? It does really focus this year, particularly on not only our service user experience, but the work that our carers have done in ensuring that we're hearing the role of our carers in supporting service users. And we'll hear a little bit more about that later on. So moving on, our quality improvement programme, some of you have, who's done Mr. Potato Head today? I'm a bit jealous I haven't done Mr. Potato Head, but I'm sure I'll get a turn. And some of you have had a conversation with Rasheen and Dawn Clift around ideas around improvement. We're really well into our improvement journey now, and this is partly a vehicle that will help us deliver everything that we've talked about so far. We've got 60 plus projects ongoing in the Trust. We're developing our central team, which is nearly to full capacity, but not quite, that's there to support you. We've selected our information system, Live QI, which is there to support you managing your projects. And there's a real frisson and an excitement about what's going on. So welcome to new members of the team, and congratulations to all of you who are already embarking on that exciting journey. And later on, Dawn and I, Dawn mainly, is going to be announcing the winners from the Break the Rules Challenge, which I think people have really bought into very well and has been great fun. But really, quality improvement is at the heart of everything we do, and it is a way that will enable us to deliver consistent quality of care, and it will also help us manage the resources, the people particularly that we have, the skills to direct them to give the best outcomes for all of you. So we're now going to ask my colleagues one by one to come up and help me with this presentation. They're our subject matter experts, and I'll come back at the end. And I'd like to thank, in advance of that, Dr. Nat Rowe, Catherine Allen, Maureen Johnson and Kerry Webb, who are going to come and talk about keeping people safe, reducing the numbers of deaths in our organisation, and working with our families and carers. And I'll just come back at the end and tie up with our learning lessons. So if I could welcome Dr. Nat Rowe to the stage first, I shall step aside. Thank you.
Hi there, good afternoon. Everybody, can you hear me at the back? Excellent. So I'm Dr. Nat Rowe. I'm a forensic psychiatrist, so I work in a low secure unit in Birmingham, and I've got a ward of that I work with service users, but I'm also the Deputy Medical Director for Quality and Safety. There's quite a lot of different things in my portfolio, but the positive and proactive care is one aspect, and I've just got a couple of minutes just to tell you a little bit about what we do. We've got 10 work streams, and there's about 10 different clinicians from different areas of the Trust and different disciplines. We meet together every month looking at data, looking at qualitative information from service users and teams, trying to think about different aspects of restrictive practice and also safety of staff and service users. And I just wanted to bring out 4 little areas really, just to give you a flavour. People that know me know that I could talk all day about this, but I've only got a few minutes. But just 4 key areas, just to give you an idea of the kinds of things that we're looking at. So the first one is seclusion. Now, some of the work streams that we look at can be quite distressing for people, it's really getting into the nitty-gritty of day-to-day work in a mental health trust, I guess. And although lots and lots of service users come into hospital and never have to go into seclusion, occasionally that has to happen. And I think that nationally that's recognised that unfortunately sometimes seclusion does have to be used, but where possible, can we make it as least worst as possible? So for each of these areas, we've got some quotes from actual people, either service users or staff. Again, just to give you a real flavour that this is what people are doing day in, day out, and to try and make it as real as possible for you. So you can see that some of the quotes there have come from service users just in the last few weeks in terms of their views. And over the last 2.5 years, the Positive and Proactive Care panel has done lots of work around seclusion, gathering quantitative data, so looking at the length of stay, why people might have gone in, how long they're in for, are reviews happening, those sorts of things, but also qualitative information, so feedback from service users about why they think they had to go into seclusion, their experience when they're in there, and then when they've come out, they've reflected on that whole situation to think about what might happen in a different way for next time. And likewise for staff, because staff generally are trying to keep everybody safe, but sometimes isn't a great experience for them either. And I think we're really mindful of all the different information that we've heard, that's really important to remember. So some of the things that we're trying to do, in addition to the ongoing talking about this issue with people that come along to the panel, there are 3 different quality improvement projects that are looking at different aspects of seclusion. So one is about the length of seclusion, one is about the experience of service users and of staff, and one is also about a debrief, so having an opportunity to reflect afterwards how that could have gone differently and what might be better for next time. So next area is safe wards. Just put your hand up if you've heard of safe wards. Oh, excellent. That's good. So you'll know then that this is something that's nationally accredited. It's a series of, I guess, formal modules of really common sense, good clinical care within mental health wards. And all of our staff have now been made aware of this practice, I guess, within inpatient settings. So my co-chair of the panel is Dave Jeffrey, who can't be here today, but he works in the averts team, he leads the averts team. So Safe Wards is all about trying to avoid confrontation and trying to put things in place before you get to that situation where things might be escalating. So some of the quote here is from a service user where Safe Wards has actually been used quite successfully on that particular ward. And the wards where it's been fully implemented generally gives a really positive view from service users but also staff. Things like getting to know me. So if you're admitted to a ward for the first time, it's a really quite scary experience. You don't know the system, you don't know the staff, you don't know the other patients, and just trying to familiarise yourself and knowing that there are other people around who will try and help you settle in is actually something that will really reduce your anxiety, independent of what other problems you might have. So again, one of the actions, Safe Wards is one of our work streams, and one of the actions is about trying to continue to embed all of the different modules in different ward areas, and in particular some of the areas where there are more specialty services, so for example the deaf services, and how this might need to be adapted in those areas. The third area is positive behavioural support plans. So this is something relatively new in our trust, although we've been using them in secure services for a while. And again, they're another tool for service users and staff to work together to try and help things just become a little bit easier in inpatient settings. So again, you can see some of the quotes there from service users. The quote is on the left is from service users, the quote on the right is from member of staff. And again, so there's been ongoing training that's been rolled out through secure services, but actually there's been quite a lot of interest from other inpatient areas as well about how this can be used. And then the final area is staff support. So in addition to all the things that we've talked about from a service user perspective, we're really keen to keep staff safe as well, for lots and lots of different reasons I'm sure you're aware of. And one of the processes that has been going now for a couple of years is Operation Stonethwaite. So this is about where unfortunately staff are sometimes assaulted at work. Sometimes when the police are called, because there's been a really serious incident, it's sometimes really hard to get the police to continue those charges for all sorts of different reasons. And from a forensic psychiatrist perspective, sometimes, although it might seem a really hard thing to do in that situation at the time, in the longer term, there are sometimes some benefits for that service user getting the help that they really, really need. So the support for staff in those circumstances is really important as well. And these are some quotes from different staff members who have been through the process, and it's really helped their confidence, I guess, returning to work after a serious incident. So I think that's all of my slides. Yes, thank you very much.
Thanks, Nat. Good afternoon, everybody. So my name is Kerry Webb, and I'm here as the Suicide Prevention Lead this afternoon. And much as Nat, I'm just going to spend just a couple of minutes or so going through some of the key areas around the suicide prevention work that the organisation's involved with. From the work that we've been doing, we've realised that there are 6 core areas that we really want to be focusing on at the moment. And they're the areas which we're currently pulling together in the revision of the suicide prevention strategy. So I'll just go through each of those briefly to give you an overview. The first one is around working towards an ambition of having no inpatient deaths. People sometimes do die on inpatient mental health wards by suicide, but it's something that, as a mental health organisation, we really feel that we want to try and take responsibility to try and make as much of a never event as possible. We'd like to have an ambition of making our wards safe places so that when people come in, they can be cared for and treated on our wards safely. This is it is a big challenge. Suicide can sometimes be very unpredictable, but what we're trying to do is learn from the lessons, learn from our experience, and learn from the experience of others to try and look at some of the things that will help us to make practical differences on the ward. And some of those things have been things like, well, the safer ward stuff, for one, that Dr. Rowe's been talking about. We've been working with staff, so staff training has been an important part of it, raising staff awareness around the risks around suicide. We've done work on the observation policy for nursing staff, and we've brought in new technology, apps and so on to help staff improve their practice around observation of patients when they're on the ward. And we've tried to embrace new technology where it's possible. So we're currently trialling anti-ligature doors on 2 different wards across our trust to try and see if that might just help try and make the environment safer. The technology is something that we're always looking at, and it's always that trade-off around how do we invest our resources, what's going to make the best impact, and what's going to try and help staff to keep people as safe as possible. So trialing these things and then reviewing these things is something that will help us to learn some of that. The other area that we're focusing on is reducing deaths of people with a severe and enduring mental illness. That might sound obvious as a secondary mental health trust, but I think there's very much a drive around wanting to get the quality of treatment right. So, speaking with a lot of our psychiatrists and senior clinicians, what they'll say is if we can optimize our treatment for people and get in there early and give people the right treatment and make sure that we give them the right evidence-based treatment, that will help them to reduce the risks around suicide. And again, coming back to the training, it's about staff being aware of the risk of suicide for people with a severe mental illness. And then the other areas for people with a diagnosis of a personality disorder, again, the risks associated with suicide and with personality disorders are well known, but it's about giving staff the empowerment and the resource and the training and confidence to be able to work with people who are very challenged by this condition, as well as working in a very co-produced way. So there's been a lot of work done over the last couple of years in terms of developing the personality disorder strategy with a focus on co-production, evidence-based treatment, and training staff as well, and producing training packages. I think probably to echo what Regine's already said today, one of the things that we're really focusing on is trying to do the right thing by our staff and trying to invest in and support our staff with a belief that if we do that right, then that empowers staff to do the right thing by our patients and service users. Suicide is probably an area where we really need to focus on this, because I think we shouldn't underestimate the impact of suicide. We quite rightly think about suicide for the individual and for their family and loved ones and the people around them. But sometimes I think we underestimate how staff feel about that, both as professionals but also as human beings. And I think in the past, sometimes we've been guilty of not appreciating that. And I think what we're trying to do through moving on in the culture of the organisation is understand that narrative and try and support staff to be able to work with people in a compassionate way, and to be compassionate with staff and to support staff when things go wrong. And I know certainly through the work we're doing with suicide prevention and through the work in some of the areas in which I work, our staff and our managers and our leaders are really trying to be supportive and trying to set that right culture for people. If we go in with a culture of blame, people do become defensive, people do withdraw, and people do shut down, and they're not responsive to learning from mistakes and making our environment safer for people going forward. So that's a focus for us. Alongside that, again, Dr. Rowe's been leading on the Compassionate Workforce Group, within which there's a subcommittee where a group of people are trying to look at developing a set of standards and again, a sort of cultural contract really around how we do support and put in place doing the right thing for staff when there are suicides that occur in the organisation. And that's again about having the right approach, making sure staff feel supported and feel psychologically safe to be able to go through a difficult process. And Amanda Gatherer, who's our senior psychologist, has been on some TRIM training, got a group of staff who are going through TRIM training now, and has actually been putting that in practice, going out and reaching out to some of our staff where we have had people die by suicide, and has been working with those groups of people to help to contain and support and allow people to work through the process of that post-vention grief and support work. So I think moving on from that, the other area obviously that's of equal importance, and the two sit side by side and quite rightly should, is improving the experience of families. The organisation again, I think, is quite rightly trying to make sure we work in a very open and transparent way with families of people bereaved by suicide. That's a very challenging thing to do when there's loss involved and when people are feeling very raw and very hurt. But again, it's sticking to the core principles of that and trying to drive that through. To back that up, the Trust has appointed a family liaison worker to try and help make sure that we do have good interrelation and good communication with families as much as possible. And as part of the staff training that we've developed around suicide prevention, we've also co-produced a video with a relative of somebody who died by suicide who wanted to again, put across their experiences as a relative, but also wanted to try and give clinical staff a steer about some of the things that they felt that we could reflect on as points of learning moving forward. So again, that collaboration, that time to be able to listen at the right time is something that we're working on. And then I think probably the last bit I would talk about is just about research and learning lessons. From a learning lessons point of view, there are governance structures within our organisation to try and help keep us safe. So we have things like serious investigations, which we work on with commissioners. We have a serious investigation group, which then tries to review those incidents, try and learn from some of the lessons from that. We have a mortality review group, which similarly tries to look at patient deaths and things that we need to learn from that. And we've also been working closely with universities as well. So we have a research and innovation department. And some good news this week is that our research and innovation department have been working with the University of Birmingham. And I met with one of their academics yesterday. And actually our trust has been appointed as a lead for a feasibility study now for a new cognitive behavioural therapy trial to try and reach out to people who have recently tried to take their life by suicide, to see if there are some interventions that we can do very early on, particularly when people present at A&E or at general hospitals or within mental health services, to see if we can just try and shift some of the pattern of thinking and stuckness that people get stuck into around some of the suicidal thoughts. So again, just trying to always look at research and innovation, learn from other areas, as well as learning from ourselves and things that haven't gone well, to see if we can put that right and improve quality for the future. So on that note, I'll leave it. Thank you very much.
Good afternoon, everybody. I'm Catherine Allen, and I'm the lead for recovery and service user and carer and family experience. So we're just going to talk briefly about our new family and carer strategy. I'd like to introduce you firstly to Maureen Johnson, Carer Governor. Maureen's been really integral to the development of this strategy, so she's just going to give an overview of some of its key principles. Thank you.
Thanks, Catherine. Right, the family and carer strategy. We've reviewed the previous strategy. I think that was 2012 that was first set. We've kept the same guiding principles that were led by carers, but we've developed our own ways of implementing the strategy now across the Trust. And we have 5 guiding principles. The first one is identifying and recognising family and carers. The second one is working in partnership with families and carers. The third is to support families and carers, sharing and providing information, and then improving the involvement of families and carers. And our thanks must go to certain individuals for supporting this development. The Carers Voice Group that's provided vital input into the Trust. Where is she? Sandra Baker, the carer lead for pulling the strategy together. The Meriden Family Programme for their support, particularly around the carer pathway. And Dora Francis for the strategy design. Thank you.
Okay, so we've got the strategy. Obviously, a strategy is only as good as how it's implemented. You can find a copy of the strategy at the back on the Recovery College table. I'm just going to talk about 2 ways in which we are hoping to implement the strategy. And really, it's building on a lot of work that's been going on anyway. So the 2 key ways of implementing the strategy are our family and carer pathway and our experts by experience programme. So the family and carer pathway sets out what carers and families can expect from our trust. So it's got 5 elements that support the strategy's 5 principles. I'm going to read those 5 elements out, but I just wanted to recognise that a lot of this work has happened already and a lot of these things we're doing already. So really the key part of the strategy is to make sure that that is consistent and across all of our services. But some of these things you should recognise and should have experienced anyway, or if you're a member of staff, you are doing already. So firstly, we identify and record the contact details of carers and families. Secondly, we will provide, and we do provide, service information and key contact details for carers and families to contact when they need. Thirdly, we're going to offer a meeting to discuss how carers will be supported, involved and included. And we're also going to offer a carer engagement tool for people who wish to take that up. And then we're going to involve families and carers, as we have been doing, but we want to develop further the involvement of people through our Experts by Experience programme. And again, there's details at the back on the Recovery for All College stand about the different Experts by Experience opportunities there are. So we're encouraging service users, but we're really keen to get more families and carers involved as well. So some of the ways that people can become involved are being part of our quality improvement programme. It's really key that we get service users and families and carers involved in our quality improvement projects. We also have our family and carer strategy. We need support from families and carers to implement it and evaluate how we're implementing it. So we mentioned Carers' Voice, who are absolutely integral to the development of the strategy. That group is now called the Family and Carer Strategy Group, and Maureen's a key member of that group. So if you're interested in implementing the strategy, come and join us. We're also developing opportunities for people to get involved in research in the Trust, which is really exciting. And also things that we've been doing for a long time, like families and carers sitting on interview panels for our recruitment and selection of staff. So I think that's it. Thank you very much. Come and see us, and we look forward to working with you. Thank you.
Thank you very much to my colleagues and experts for the wonderful work they do and the leadership that they show, and what a wonderful organisation we are. Much better that it's developed by all of you. Fantastic. And I have to say, in my 5 and a bit years, this new strategy is absolutely magnificent. And as I wrote to the team, and when I read it, it brought a tear to my eye. It's been a long time coming, pulling it together. A special thanks to Maureen, who's, as I always say, been that audible voice that has reminded us constantly that we needed to do this. So it's really great. So thank you all for that. So just to round off before we move into the next session, we want to be an organisation that remains curious and learning, to always strive to get the best for service users and carers. And to do that, we do need to learn lessons. And this pictorial diagram just shows you the way we do that. So the column in the right-hand side, for those of you who are unable to see at the back, tells you where those lessons come from. And as Kerry mentioned earlier, things like serious incidents, things like complaints and comments and PALs, from our audit programme, from best practice, from CQC or regulatory visits if our commissioners have been. We pull together that intelligence and seek to understand what we need to learn to do better. And we turn those into various ways of sharing with the organisation. And what we go on to see in the middle tranche of the slide is that we embed that into supervision, into our team and local meetings, through a range of structures, including clinical governance, but local team meetings. We use risk and practice alerts. Some of you in the room will be familiar with those. Our Take 3 videos, which are 3 key messages in 3 minutes for people to understand. And we distribute a learning lessons bulletin. And ultimately, that's to improve the safety and experience of our service users and carers. And again, doing that through living our values. That's just an example of where those lessons come to life. So in the top right corner, to me is Rebecca outside the Meriden programme, where there's a 3-minute video for 3 lessons about family and carer involvement, and again a pictorial of the bulletin. Aware of time, so moving on to the last slide, very briefly, just to tell you what we're looking forward to now in the year we're in, is to continue really and build on the work we've done so far, to really to build on a clinically driven and consistent approach to quality improvement across the organisation. And as I say, I think we're well into that journey, so thank you. To provide services which ensure that mental health and physical health care needs are assessed and given equality of consideration when developing, planning and delivering care. Because as we know, we are a whole people. We don't bring just our physical or our mental health. So actually we're doing some great work, and again Dr. Nat Rowe leads our physical health committee, and we're really pushing on with that, and thank you to all of those clinical practitioners that are working hard on that agenda. And for our service users to have reduced mortality through co-produced crisis plans, absolutely critical. Learning from mortality case reviews, where we are doing that work to really make sure that we can give optimum services for people. And to embed that culture of least restrictive practice and reduce the incidents that relate to prone restraint, seclusion and physical assault. And finally, to continue to promote recovery and hope, co-production and family care and service user involvement. So thank you for listening to me today. It's with great delight and pleasure that I hand over now to Dave Tomlinson, my colleague, Director of Finances. Thank you.
Okay, thanks, Sue. Just for a start, I've had a message from reception. We've just got some lost property in the place. So can you just have a look under your seat if you can find John Short's bicycle clips, please? And then the second one, there should be a white envelope somewhere, a parcel. I think, in fact, it's just under you, Dawn. Can you just pass me that? Okay, apparently it's our brain cell. It says, please return to NHS England. So we're right now then. So I'm just going to run through the finances for the year, but I just want to do something first. I'm just really pleased as being the exec lead for the Disability and Neurodiversity Network that we've got some signers here today. Now I asked in advance, is there anything I need to avoid? And they said, try not to go too fast. It's okay if you go a bit slow, but never say anything about really difficult words. So let's try onomatopoeia. Or supercalifragilisticexpialidocious. Go on, all right then, I'll leave that one. Okay, so just do this slightly differently from normal. Just start with just a multiple choice question. So why is it important for us to perform well financially? So if I ask for a show of hands for each of these as I go through, so it's always good to have lots of money in the bank. No, you can put your hands up if you want. When I say a show of hands, right, so a couple, right. So it enables us to pay our staff. Okay. We're told we have to by our regulators. Right. It means we can invest in buildings and services. Okay. It allows us to improve the quality of the care we provide. It isn't. Plenty of NHS trusts are in a deficit and nothing bad seems to happen to them. Okay. So the answer is actually, it's so we can reassure the regulators. We don't have to answer to them, but if we've got money in the bank and we look good, we're able to get on with things. It does mean we can pay our staff a greatest asset and therefore biggest areas spend. Gives us room to invest in building service and new developments, and allows us to concentrate on quality. Good finance is important, but it's not an end in itself. If we haven't got the money, we can't do things. So it's important we do well, so we can remain in control and then do something with the resources that we've got. Another just a question. So to try and put in the context how big or how otherwise the trust is, which of these do you think we're closest to in terms of income? So if we just go through Holland and Barrett? I didn't know who this was. Louise said everybody will know Holland and Barrett, but you know. Birmingham Airport? Wagamama? So none of them then. Okay, so it's actually Wagamama. So we're equivalent to a mid-sized business. It's quite large for an NHS trust. And I always look at, actually, rather than talk about the 10 million or whatever we have to save, let's talk about the 248 million pounds that we have to spend. And the secret is how well we spend that, not how good we are at cutting. So how did we do in the year just gone? And this is quite complicated, the way this is laid out. It's an interesting story because we have to generate a surplus, but then we get money for doing so. So what we start off with the year is a plan of 150,000 deficit, i.e. we can spend 150,000 more than we get. That's the plan that was set as at the start of the year. We achieved against that a surplus of 55, so we were doing a little bit better. We didn't spend quite as much as we got in. As a result of that, we get 3.5 million from NHS Improvement, just for doing what they asked us to do in the first place. But it does mean we've got this actual, basically a break-even position, but that means we report a 3.7 million surplus, so people go, why is there an issue? Well, we can't spend that 3.7. We get it, we get the cash, we can spend it in capital the following year, but I can do nothing with it during the year. And then you'll see in the actual accounts, there's also a technical loss of nearly 9 million that's around a change in valuation of the assets, the property. And you don't need to worry about this. It's a technical adjustment we put through, but it's to explain what sits in there. We delivered over £7 million worth of savings against a plan of 10 million. So we did pretty well, and that's a sizable saving. It's not where we expected or wanted to be, but it's a sizable saving. And it goes with the last 5 or 6 years where we delivered upwards of about 40 million quid. That makes it, in savings, that makes it really, really difficult when you look at efficiency, because we've taken a lot of money out of the system. And we did invest nearly £8 million in capital development, so renewing things, doing a lot of building, development of services, development of tech. We do plan in the years ahead to spend quite significant sums around the redevelopment of Highside and Raycroft. No, Highcroft and Rayside. I remember when I was up north, we used to have these 2 CCGs. One was fouled and one was wire, and it was far and wild, but never mind, anyway. I'm not very good at this. But we're planning to spend tens of millions on these 2. So the 2 of them, altogether, it's about £100 million. Now, we can raise that cash and able to support it on an ongoing basis, but there's this difficulty with the central grip in the NHS. We're not certain we'll be allowed to raise that money. So this thing that Sue talked earlier on about command and control and what happens around that, they're saying other people have got real problems, so we have to lend them the money. If I give it you, I've got less to give to others. What's that saying is, I've got money in the bank, I've got a problem anyway because I've got to replace, but there's a failing organisation somewhere else, so I can't spend my money. It just seems perverse. And that's the sort of things that we've got to cope with. But if we're in a strong position, I'm able to make sure we can use the money that we've got in the way that it's intended to develop and renew the estate. Okay, so just a brief slide around the single oversight framework. This is a risk assessment that is how other people view us financially. So they look at things like quality care, financing use of resources, how we do well against the plan, and elements like that. And they assess us at the end of the year or on an ongoing basis. So it's a 1 to 4 score. 1 is really good, 4 is pretty awful. We're at 2, and we've been at 2 for the last 2 or 3 years. So we're good, we're where we need to be. We don't try and spend a lot of money in being really, really good at things, but we want to be good enough to do what we need to do. So then just to talk a bit about what some of this means in layman's terms, if we're performing well, so well, and we are a really strong trust financially, why do we have to keep on making savings every year? So just an example to try and show how this means. Meet Tom. Clearly, he's in an acute trust rather than mental health because he's got blue gloves on. So, Tom's a nurse who works at a local hospital. He takes home every month 2,000 quid. Out of that, his expenditure, 650, etc. I'm not going to go through all those, but that means his total outgoings is 1,900. So every month he's got spare, or a surplus as we call it, £100. Okay. So how does he manage his money? He plans to put away that spare £100 each month, his surplus. He's got 1,000 quid in the bank for unforeseen expenses. We'd call that reserves. He's heard he's getting a £50 pay raise, annual uplift. But rent's increasing by 50, his travel costs are going up by 50, 30, and his utilities and other costs are going up by 50. That's what we call cost pressures. So he'll actually be worse off by £80 a month. We'd call that financial gap. So the difference between what we've got and what we've got to spend. So how can Tom stay within his budget? He can find a way to reduce his outgoings by £80. That will be a savings target. That's what we describe. He can do this by walking to work some days. That will be productivity or a CIP, cost improvement program, or efficiency. He can work some bank shifts, call that income generation, but that's going to be difficult to maintain for long because it means he's working 6 days a week forever. He can't do that. So that will be temporary. We'd call that non-recurrent, but that's all these terms mean. So if he manages any of this, the bank manager's happy. So that's NHS improvement, the people that manage our outgoings, try and make us live within our means. And if he can't, the bank manager might foreclose on his loan, intervention. But that's Tom's problem, not other people's. So in our situation, we get money in, we spend it well, we have to generate surplus and we have to get cash in the bank to pay people, to develop things. If we on an ongoing basis spend more than we've got, we can't afford to do some of those things. You get into recovery, you get out of control, you get people driving you. So what does this mean for us? So we have got a strong financial track record and liquidity, and that means we're considered low risk by others. Quite difficult this year because we're in a difficult situation because we've got a large savings target. But at the minute, we're in charge of our own destiny and we're free to invest in service and quality, and that's a nice place to be. It's important that we use that freedom well and the resources we've got well to deliver the best that we can, and also to work with the commissioners to how do we best spend between us the money that's available in Birmingham for the patients, for the population. So we're in a good, strong position. However, very challenging world, and we have to remain watchful and disciplined around it. Okay. So if you do want to read the really riveting book that goes with all this, My Life's Work, you can get it by any of these routes going through. It does include the annual report, which we try to make readable and useful, but it's very clearly prescribed what you have to include and how you present it. The quality report that talks about some of the things that Sue talked about, the financial statements and the auditor's opinion on that. Okay? Thanks very much. I think I'm handing back to Sue.
Okay, there was a lot to take in those presentations. Usually, having gone through the presentations, the questions that come from the floor aren't about anything that anybody said anyway. But this is the opportunity for people to ask questions of executive colleagues, any of them, on anything that they've heard or read, or indeed anything that's on their mind. We've got some microphones so that you will all be able to hear what's being asked. So, are there any questions? There's, hang on, there's on the side there, there's a gentleman right at the back. And then, yes, over in that back corner. Yes, gentleman in the middle there. Yes, you, sir.
Good afternoon. My name is Dr. Rob Ragpost. I learned from the lady in green, Miss Williams. I happen to be in your group, which you shared this morning. There was a patient who told us that she has to wait 8 months before being seen by psychiatrists. You told us just about predictable technology. How is that possible? My second thing is that the second course we followed was on the LGTB program. That was absolutely superb. But what was not superb, that half the audience disappeared. So there is a lesson to be learned amongst yourselves. Thank you.
Okay, thank you. So the first part of your question was about long waiting times and how that would link to predictive analytics. And of course, I mean, there is a dilemma there, because if we can predict a problem, can we then ensure we've got the people to intervene? Who wants to pick that up? Sue? Got the mic there.
Thank you. So I think predictive analytics is part of it. So supporting people, recognising when a crisis may be emerging, working with families and carers. But the other bit I think that Rasheen, our Chief Executive, was also mentioning was about the skill set of people around you, so that if there is a wait to get to the registered professional, what we need to have is a blended model of skill set, when we might have an expert by experience that might be a contact with you and the family to navigate you and support you through a process. So that's the journey we're on at the moment, is working in partnership with our colleagues around skills and looking to the future to use technology to help identify things early and navigate. So it's a journey that we're on. It's not something that is happening immediately, but it will be happening.
Okay, and I take on board, I mean, your second was a comment. I absolutely take that on board. Something, yes. Right, I think it was Tamar was next.
I just got two questions. So the first one is that as we're a disability confident employer and also a mental health trust, just to ask if we can start to show the breakdown of what percentage of spending from our public and patient involvement funds is allocated to service user led initiatives, and also posts that openly require use of lived experience of mental health conditions. So that would include posts like peer support workers. So I'm just wondering if we can include that within the annual report as a breakdown next year.
I can't give you an immediate answer to that, because we'd have to look at what the data currently shows us as to whether that's something we can pull out or not. But we can pose that as a question to go back to perhaps the audit committee as to what can the information tell us. It's not always easy just to flick a switch and say, you know, that answer could come through. So we'll take a note of that as a question to pose to our finance people. Okay.
Cheers, that's great. And then the second question kind of leads on from that. And again, it's around inclusion, which is a big part of the presentation that we've just had. And just really asking if we can start to collect data on staff. That's all staff who work with protected characteristics. So that would include ethnicity, sexuality, gender and disability. But particularly thinking about mental health disability as well, so that's often something that's invisible and unseen, and there's a lot of stigma working with the mental health services around that. Also, discussions with our staff networks have indicated that we don't actively collect this data at the moment. So it seems like it's a really important part of the jigsaw that we're missing, and the reason why is because if you're not counted, you don't count. And without understanding, you know, what's going on at the moment, it's going to be hard to evidence any barriers that staff with protected characteristics face, or know what the needs of our staff are. So the question again is, can we start collecting that data?
There's a good deal of that data which we do ask staff to give us. I think I mean, part of the difficulty is staff don't always want to. So Sue, do you want to say something more about that?
Lackbeer, are you still in the room? Lovely. If you connect with Lackbeer afterwards, what I don't want to do is misrepresent the truth, but I was at an event recently where I believe that is part of a standard that we're going to be formally requesting everybody to disclose should they want to. So your ask is that we will be asking. Of course, the commitment is asking people to be honest and tell us. But the person who will have the accurate detail will be Latvia. If you want to pick up with Latvia at the end of the AGM, that'd be really helpful. Good question, thank you.
But you know, not everyone will want to answer that question. That's been a long-standing problem. I mean, a couple of years ago when one of the national bodies was doing some work on the diversity of boards, our figures looked atrocious, but it was because 2 members of staff who were from ethnic backgrounds had not wanted to say that to 2 members of the board. So we knew the figures were wrong, but people make a choice about what they, how they want to describe themselves and what they want to declare. Okay, is there anyone else with a question at this point? Yes, 3rd, 4th row back.
Hi, Kath Gilliver. I was just thinking about inclusion, and this is probably the 3rd AGM I've been to in a row. And the work of the homeless mental health team and the homeless primary care team hasn't been mentioned at any of those. And I'm just making a comment, really, that I think because homeless people are some of the most marginalised people and also people with intractable mental health problems and difficulty accessing services, it would just be really nice at some point to showcase the great work that those teams do. And I know, Roisin, you recently went out with one of the outreach workers and you were very impressed, I saw on Twitter. So I know it is valued, but just for it to be more publicly acknowledged, I think.
Okay, thank you for that. I mean, actually, that is also something that our governors had a presentation on that work just recently, and that in a public meeting. So it's certainly something that gets board attention, but I take your point that it's one of the things we need to celebrate because it is very important. Okay, I'm not seeing any further questions at this stage. So, oh, Mushtaq, sorry.
I just want to ask you.
Take the mic. Yeah, you should use the mic. You need to use the mic because if there's anyone, yeah.
I just want to ask you. People are here on the conference, and some people are insecure in a hospital where they not here. So can they access this AGM? Another question about the inpatient death zero policy, and I am all for it. How about having zero restraint policy, which nobody mentioned it? And about the safe ward, how many we got in our trust?
Okay, so the first question, the whole reason that we were hoping to live stream, and in fact at some point after the start of the service, the meeting, we did start to live stream. The whole reason for doing that was actually because we'd had questions for a couple of years previously from people in secure services who wanted to be able to see what was going on. So yes, we've been live streaming, and that's been accessible to people in secure care. And last year they did access it. Zero restraint. I think there would be real hesitation from our clinicians about adopting that as a policy. And I suspect if you were to ask service users and carers who've been in patients and carers of people who've been in patients, they would have some real hesitation about whether that should be adopted, because they would have real anxiety, I think, about sometimes it is necessary to keep people safe, sometimes to keep the individual themselves safe, and sometimes to keep other people in the ward safe. So I think you would need very, very careful thought and significant consultation with a lot of people before you adopted a policy that said to staff, you may never use restraint.
Some of the foundation trusts are using zero policy because they have a different trainee method. Zero means not zero. Zero suicide means not zero, maybe it never happened, but where you train, where you behave, where you act, then you go to policy, other A and B.
I mean, we can explore that in great detail in other places, which we constantly do. It's something that's always under consideration. Now, whether that was your comment, there's all sorts of other questions, but you also asked how many safe wards. Is it everywhere now, Nat?
Yes, so every single inpatient ward is using at least some of the modules. So some wards are using all of the modules, which is really good. Some wards are using some but not all, but the work over the next year is to help the wards that aren't using all of them to get to a point where they're using all of them as well. So I'll let you know.
Okay, now, I think it might have been Mushtaq's question that's good. Loads of people have suddenly popped up as wanting to. So right, there's two people in the back, right in the back row there under the staff network. So do you, the lady who's got the mic now, and then pass it along to your colleagues, sort of two to the side before we try and answer. Okay.
Yeah. Sorry. My name's Anne from the Recovery for All team. Just in response to Mushtaq's question, the Recovery for All team are working with the Averts team to look at co-producing the Averts training. So it's at the very early stages, but just to say, relating to restraint and positive and proactive care, we're looking into that. And so there will be opportunities to get involved, both for service users, carers and staff as well. So it's at the very early stages of that.
Hello, I'm Chevelle, a service user. I was just wondering what's being done in regards to getting people back into work.
Okay, a very different question, but something that we do know is really important. Where's Charlotte gone? There's some work going on at a regional level about ensuring both that people who are not in work can get back to work, but also people who are in work who become unwell can stay in work. Charlotte, tell us something about that.
Yeah, really good question. So we're doing a lot as a trust already through our what's called IPS, which is about integrated personal support to support people back into work. So we've got teams of people within our community mental health teams that work with departments who work in pensions and others to actually help people back into work, which is great. And it's taken us a while, but they are actually now embedded within our team, so it's really fantastic that we got that as part of our services. But we want to take that even further, so we've been doing a lot across our STP to try and encourage others to do more in that. So it was probably only about 2 months ago we got the acknowledgement for a sort of 6.8 million bid, something called the Midlands Engine Room, to work with employers in this region to do more around mental health at work. One, so not just to support people back into work, but also to keep people in work and actually thriving within their job. And there's more happening across the UK as well in this in terms of supporting businesses to do even more. So I think keep your eye on this space because it is something that is really, really important. You know, people's lives aren't in little boxes and being in a job is really important to them. So fantastic question. I can't see the spot where it came from because it's behind me.
Yes. Yeah.
Thank you. Yeah, good question.
Okay, thank you for all those questions. If you've got more, then do catch people at the end. But Fahim is waiting, and probably nervously, because it's unfair to put him on last, really, because he'll have been on the edge of his seat all afternoon. So I'm delighted to hand over to our excellent lead governor, Fahim Odin, to say something about the work of the governors over the last year. Fahim.
Where's Sharon? Is Sharon not going to join me? Sharon? So for those that don't know me, my name is Fahim. I'm a service user and I'm also a trust service user, governor and lead governor. And this September, it's going to be exactly 16 years since I started volunteering for the trust. And this is...
I'm Sharon Maidley, and this is my third month at the trust.
Okay, so should we play the video first?
Yes.
Okay, so we're going to play a video first, and then I'll go and talk a bit about a few things, and I'm really sorry if I'm going to repeat myself, but because everything I want to say has been said before me, so you're going to have to listen to it maybe twice now. Okay, so we're going to play a video of some of the things that our governors have been getting up to over the last year.
Hello, I'm Maureen Johnson. I'm Carer Governor for the Trust.
Hi, my name's John Travers and I'm a non-clinical staff governor.
My name is Mustaq Mirza. I'm a service user governor.
Hello, I'm Tony. I'm a carer governor. I'm Khalid Ali, public governor.
Okay, my name's Rob DL and I'm the public governor for South Birmingham area.
I get involved with a number of things that are going on in the Trust. The Recovery College mainly is one of the things I'm really interested in. And I'm also involved with the patient panel for Solihull Healthcare Partnership, representing the mental health side of things. I'm also a coordinator for the Solihull Rethink Mental Illness group. I attend various STP partnership events, seminars.
It's been my first year as a governor, so I've been lucky to be able to go on some training and improve my skills so that I can help the board do a better job to make our trust a better place to work.
So at the monthly meeting I do positive mental health group meeting, Recovery for All Forum, Recovery College for Advisory Group, Recovery for All Steering Group. I sit on interview panels and I do CCG co-production in mental health, and I sit Justice Network and Soul Search meeting.
I've been privileged to attend Recovery College meetings, as many board meetings as my caring duties will allow, and also of course Council of Governor meetings, and I'm particularly active at the local Rethink group, and I try and spread the mental health message throughout the community that I'm part of.
As a governor, I represent the views of the public in Council of Governors meeting, and also I attend on a regular basis the Trust Board meetings, which are held on a monthly basis.
As a governor, I take an interest in some of the open events that happen during the year at different locations around the Trust. But I suppose more recently I've been particularly interested in some of the work that's been going on around inspection, Care Quality Commission inspection, and what that means for the Trust, the opportunities that lie there for learning and future development and improvement.
It's important for governors to be able to get involved in the meetings so they can learn about what's going on in the Trust, and also to attend regular events outside of the Trust as well in regards to mental health services and issues.
Spreading the word is very important. Mental health is not a beginning or an end, it's the start of a journey, and anything that I can do to help in any way, shape or form, I welcome. I was volunteered for this job by a previous governor, and I think he did the right thing by volunteering me.
I think the governor should attend group meeting as to have a better understanding of who they represent and of what working well and what changes still need to be met.
Well, I think the key for me is that governors bring a wide range of different personal experiences and knowledge to different situations, and they're able to contribute to the conversations and dialogue in a way that brings different perspectives, brings a challenging and often inquisitive approach, and can sometimes get others to reframe their views, reconsider their opinions, or reflect on their approach. And I think that's the most valuable part of the governor's role.
I think it's really important that non-clinical staff have got a voice and are heard directly by our colleagues on the board, because they've got a really important part to play in delivering high quality care. In my day job, I'm really lucky because I get to speak to and travel around the trust a lot, talking to different people and getting to understand their concerns. And in this past year, I've been able to represent those concerns to the board.
Try very hard to represent the needs of carers, which is part of the constituency I represent. I've been involved recently in supporting the new family and carer strategy, both in discussion and its preparation. And of course, I always try very hard to attend trust board meetings and put the case of carers, and I'm very concerned about the staff and their issues, so I try to support staff governors as well. I also think it's very important to have carers and service users on interview panels for new staff for the Trust. All the Solihull governors meet about every 6 weeks, and we discuss at those meetings any changes, any issues that we have, any issues that they have that we can share with our community. One of the highlights of this year for me has been part of a very successful event for carers that was sponsored by the Solihull Healthcare Partnership. We tried to reach out to help those in need of support and signposting. The Wellbeing Community Choir supported us at this event as well and helped to make it a wonderful day.
My highlight from the past year? There are many, but what sticks most in the memory is being invited to be part of the selection panel for the new Chief Executive. All the candidates were thoroughly vetted by other people, and then they were asked to vet the members of the panel that I was part of. So it was very much a two-way process, and both sides asked some very, very awkward questions and got some very good answers.
The recognition of the achievements under John have to be recognised, and the good position that the Trust was left in, the appointment of a new Chief Executive. And the way in which that whole process was handled and went so well, I think, was something that was significant for me, and I now look forward to some new ideas, a new chief officer with some new ideas building on the strong foundation that we already have here, and look forward to being able to play a part in some of the new ideas she might have for how we move forward and build on the already strong base that we have here.
My highlight as myself, as a collective governor, we got together and we pick a topic, we make a collective decision and took it to the board, and outcome become a positive change. So as a together working as a council of the governors, we can make positive change in our trust.
I have attended a lot of events, and I've engaged with a lot of the public members in regards to mental health. In the last year, I have been nominated for numerous awards. I've not won yet. I've been a finalist for the Thrive West Midlands Mental Health Services, which is a Thrive West Midlands, which is part of the West Midlands Combined Authority. I've also been nominated for an award with the Midlands Business Community and Charity Awards as a Role Model of the Year. Previously, I have been nominated for various other events, awards as well. So I do go out there, I do attend numerous events, and I'm always engaging with people to improve the mental well-being of people.
What's important to me about being a governor is listening to colleagues and getting their views across to the board. And I believe on a couple of key issues I've made a real difference this year in helping the board to understand people's concerns in a different way and to take a slightly different path. I want to continue to help the board to do a better job in the future.
A lot of our governors do a lot of work, and I'm not going to mention the things I do, because a lot of the things they were talking about, I do them anyway, so I don't want to bore you with a list of things that I do, but normally, you know that I don't go with a script, I always say it from the heart, but I've just got some prompts here. It's not a list of what I want to say, just prompts, so it is going to be coming from the heart. I haven't been too well over the past 6-7 weeks, so try and bear with me, please, okay? So I just wanted to ask, who was there last year at the AGM? Okay, a few people. So do you remember when I started off and I had Barbara Anthony standing next to me, and I said the year before that I had Dan Conway, for 2 years before that I had Deborah Lawrenson, and last year I had Barbara Anthony, and I said, well, I wonder what's going to happen next year, who am I going to have? And Barbara had this look on her face of horror, because the company secretary position seems to be like a poison ivy thing or something, a chalice poisonous, because now I've got Sharon here, and I am hoping that Sharon will be here for a while, because I also need some stability and continuity. The year hasn't been a great year. We've had some good times, but there's been a lot of down times, and before every New Year starts, so on New Year's Eve, I'm at home, I'm lying on my bed, I have the TV on. I love Auld Lang Syne. I can't sing it, but I love it. And the only channel they played that on is BBC Two on the Jules Holland show. And from 11:30, I start praying, and I say to myself, I say to God, oh, make this next year better than the last one. Make next year better than the last one. When it comes up to midnight, I stop praying, I listen to the song, and then I start praying again. And however things turn up to the middle of January, then I know how the rest of the year is going to be. So I wrote this year off middle of January, and I was talking to someone from the research team yesterday, Sarah her name is, and I said to her, without giving my age away, I can't afford to write off a day, let alone a year, because I'm getting older, And I'll be waiting 29 years for Liverpool to win the league championship or not. Yeah. Like I said, a lot of the things have already been mentioned, so we mentioned the quality goals, and one of the quality goals we set this year that we want to see a 20% reduction in suicides. Even though we see 60,000 people each year, for some organizations, in this country or around the world, people might say, oh, even if 30 people commit suicide out of 60,000, that's not too bad. I'm afraid one suicide is one suicide too many. And I'm going to set you all a challenge today. From the end of today's meeting till we meet next time at the AGM, see if we can go through a whole year without having any suicides at all. The group that Kerry's set up about suicide prevention, I am really keen to join that group, but unfortunately at the moment it clashes with induction and I haven't been able to attend any of the meetings, but I really, really want to attend those meetings and play my part in that. Some of the other things that I've been mentioning, so I've been working really hard with the predictive analytics. And Richard, I know when you got a mention, I did say to you, if you stick with me, I'm going to take you to places, and you've been on the screen all day today, Yeah. I've been also working hard with the Family and Carer Pathway, and I'm about to start on a new project called Patient Portal. For my liking, these things are taking a long time. And normally after about 2 years, I get bored, but I'm glad that I've not got bored with these 3 projects, because I want to get them right. We want to get them right and do the right thing by our service users. I work with service users, I work with carers, I work with our staff. You can't work with one group and not the other two. You have to work together. And I get fed up of this us and them, we're all in it together. And when I say we're all in it together, I'm not talking about the Tory we're in it together. I'm talking about our we're all in it together, not the David Cameron we're all in it together. So some of the things I've done, I was invited to Aston University after the last AGM in September. And I was asked to talk to 150 undergraduates, pharmacists, And the lady who invited me, she said the thing that was really disappointed, a lot of these people graduate, but they don't have a clue about mental health. They know about medication, they know which medications interact with other medications, but about mental health, they don't know anything. So I agreed to it. I went along. I was really nervous, 150 people, and all younger than me, of course, because they were undergraduates, and I didn't know how to start, so I stood in front of them and I said, never in my life, I introduced myself and I said, never in my life did I think, I'm going to be standing in front of 150 drug dealers and talking to them. Thankfully, that got a laugh, If it didn't, I would have been in trouble. One of the other things I did, and Kath, you raised the point about working with the homeless. So recently, I was invited to go along to Cypher Fireside and speak to some frontline staff that work with the homeless. So I went there, I went along. It was a small seminar organized by a guy called Steve, I can't remember his surname. When he gets all that information together, he's going to send it to me, and I'm going to look at it, and then I am going to take it to Charlotte, and we're going to have look at that information and see where we can do better work with the homeless. I mean, it is high on my agenda on all, I wish there was more I can do for the homeless. Unfortunately, there isn't. But it is a major problem, like you said. It is a problem. And the good thing about was when I went to Cypher Fireside, it was lunchtime, and the number of people that came in and having lunch and then having showers and change of clothes and all that. I'm glad places like Cypher Fireside do exist for these people. So we are taking it seriously. We already got a team that actually does visits, and I explained the referral process to people there and also. And they want me to become a regular member of that group. And if I can have the time, if I can find time, I will do that. I will go regularly. The other thing I'm really proud of with our trust is that a few years ago, we started taking on apprentices. And the things that really, really pleases me is when I see some of those apprentices go and get full-time jobs with the trust. The first group of apprentices we took on, I actually did the induction for them, and I kept in touch with about 6 of them, and every so often when I saw them, I try and encourage them. I mean, there was one particular person, I won't name him, he was really shy, he wouldn't talk, he wouldn't have his photo taken, but I used to see him every so often. I said, look, work hard, and at the end of your apprenticeship, I want your team to turn around and say, look, if this guy leaves, we're stuffed because we need him here, we want him to get a job with the trust. Thankfully, that young lad has got a full-time job with the trust. There's 5 other apprentices that I personally know have got full-time jobs with the trust. So I'm really pleased about that we're actually reaching out to these young people, and at the end of it, they get jobs. One of the highlights for me every month is twice a month when I do the trust induction. We have our new starters, then Sue and I meet them for lunch on the second day. And because I can't just name one thing that's a highlight. Everything I do, I mean, if I've helped someone, if I've made someone smile, if I resolve someone's problems and they thank me, that's a highlight, and that pleases me the most. One of the other things I just want to touch on is stigma and discrimination. I mean, Mushtaq mentioned the positive mental health group. And we also have community engagement, and Latvia's department does a fantastic job. Latvia's department supports the positive mental health group. But it's not just down to the positive mental health group or just down to the community engagement. Everyone who's connected with Birmingham and Solihull, workers, carers, service users, it's everyone's job to fight that stigma and that discrimination. The positive mental health group tries to do its best. I mean, a few years ago, when we used to march in St. Patrick's Parade, and one of the places where we take part in is St. Patrick's Parade, and we have a big banner, and it says, be positive about mental health, and it also says the group's name, Positive Mental Health Group. And I used to feel embarrassed. I thought, people are looking at us, right, and they're going to know that we've got mental health problems. Last 4 years, when we come round and people look at us, they start applauding. And I think that's a big turnaround from where I was about 4 years ago. I mean, 2 weeks ago, we had a stall at the Moseley Festival, and the person who had a stall next to us, he was quite rude. He made some comments about people with mental health problems. I don't want to repeat here, but I was really, really upset about. But because I said I haven't been too well over the past few weeks, I did not challenge him. One of the CME workers actually had a chat with this person, but he wasn't having any of it. We also met a lady, a mature lady, I mean, in her 60s, 70s, and some of the views she had about people with mental health problems, again, I can't repeat, but basically what she thought that everyone with mental health problems should be in asylums. We should go back to places like Ruby Hill. And when this discussion was happening, it got me thinking about 3 incidents that happened a few years ago, and I thought we're taking steps forward, but with those conversations, I've realized that we still got a lot of hard work to do. So one example is when we were building the Zinnia Centre, I mean, there was a lot of demonstrations. People were totally against the Zinnia Centre. They were having placards, you know, it was all over the news. They didn't want it in their backyard. And there's a chip shop just by the Zinnia Centre, and one day I went to that chip shop. I didn't recognize the guy behind the counter because he actually owns the chip shop, but he recognized me and he said, "You're Fahim, aren't you?" And I said, "Yes, I am." And he goes, "Do you remember me?" And I said, "No, I'm sorry, I don't." And he goes, "I'm so-and-so. We used to play cricket in the same team years ago." And I said, "Oh, yeah, I remember. Yeah, we were in the same team. How you been?" I said, "I've been okay." And he goes, "Oh, before you go, can you sign this petition, please?" And I looked at it and I said, "What's this for?" And he said, "They're building a mental health unit just down the road from here, and we don't want it on our patch." And I looked at him and I said, "You know, they're building that unit for people like me." And he goes, "You've got mental health problems?" I said, "Yes." He goes, "Since when?" I said, "For years." I said, "I had mental health problems when I was playing cricket in the same team with you." And I said, "Do you call yourself a businessman?" And he said, "Yes." I said, "Well, you're not much of a businessman." I said, "Don't you realize that hospital, right, is going to be full of service users that want food? They're gonna have visitors that will want food, right? They're gonna come to your shop to buy food." And he ripped it up. He ripped the petition up. I couldn't believe it. So no more protests, you know. Then I remember when we were building the Tamarin, I mean, there was a lot of opposition around the Tamarin. And Latvia and myself, we had a stall outside the Millennium Point, and there was this one young lad there, and he was having none of it. He kept on saying, "The community is saying this, the community is saying that." And Latvia was trying to explain to him in her calm, posh voice, you know, yeah, what we were trying to do, but he wasn't having any of it, you know. And I said to Latvia, "Latvia, should I slap him one?" And she said, no, that's going to give the media a field day. They're going to say, "Man with mental health problems, slap someone," you know. But I also know that Liam Byrne, the MP who gave a talk about alcoholism a few weeks ago, I didn't come to his talk on purpose because I know he was one of the people who was against the Tamarin. So I made that decision that I do not want to go and listen to his talk, right? And the final one, I remember the Zinnia Centre. So when we were building the Zinnia Centre again, we were having Eid Milah. So we had a stall in Canary Park, and this was when I first joined the Positive Mental Health Group. So the people I was with Latvia and the other people, they left me on my own at the stall, and they all went out for a walk. So I'm standing there on my own for the first time on a stall, and I've got a model of the Zinnia Centre, and there's people coming up, picking up information, and I'm giving them information. And 2 ladies approached me. One was in her 60s, one was in about 70s, and the 70-year-old asked in Urdu, "So what was this?" So she asked me, and I took 15 minutes explaining to them what it was. It was the Zinnia Centre. It was going to be a hospital for people with mental health problems. Originally, we were going to have GP surgeries there, but that sort of fell through. So I took 15 minutes to explain all this to her. And then the elder lady asked her, "What did you say?" And she just turned around to us and said, "Pagalandi Aspatale," which basically means hospital for mad people. And I thought, I spent 15 minutes, right, telling you all this, and now all you can say is a hospital for mad people. So that's what I'm saying. It's everyone's duty here to fight stigma and discrimination, no matter where you see it, you know. Predictive analytics. With predictive analytics, there is a lot of media, you know, interest in that. But I've advised the group to let the media beg us before we share any information with them, because when we have a positive story, they don't want to know about it. So we're doing something good now, and they want to know. So Roisin, let them beg before we give them any information. Let them get there on their knees, right, and pay us before we give them any information. So like I said, we've had quite a few changes over the year. We have had so many people leave, so many people come. This is my first time that I'm going to get a chance in public to welcome Roisin to the Trust. And Roisin, just a word of warning, I have this habit of dropping people in it, okay? Not on purpose, right, but sometimes it happens. With John's predecessor, I dropped her in it about 6 times, but she was all right. She knew I didn't do it on purpose, right? I didn't drop John in it in 6 years, so if I do ever drop you in it, right, it's by mistake, not purposely, right? So, I mean, thank you for coming today. I just want to thank the comms team for organising this with the L&D, Learning and Development Department. And yes, just thank you for coming and thank you for listening. Right.
Thank you, Fahim and Sharon. The moment you've all been waiting for, and as a natural-born rebel, I'm going to hand over to Dawn, who's going to tell us all about our Breaking the Rules initiative, and we're going to be making some exciting announcements.
So hopefully many of you will recognise that over the last month or so that we've been putting big orange posters in various places across the organisation. And for those of you who work or see a computer, you'll have seen some little screenshots of something called Getting It to Bin It, Break the Rules. Now, I think when we started this campaign, there was some confusion about what on earth is this. Some people thought it was about recycling paper properly, but in actual fact, it's a campaign that has been used in some organisations in the NHS with a really, really good output. And the essence of it is really simple. So over time, as systems and processes evolve and new people work through services, we constantly change and develop the way that we work. We constantly add to our rule book. We constantly add to our processes. We audit more. We do lots of things. And actually, sometimes, in the longer term, it doesn't add value. So the purpose of this campaign was, please tell us, as a member of staff, of any of those rules that we have in the organisation that really don't add any value and that we'd be better off without. So we had around about 140 suggestions, so we were really, really pleased with that from staff members. And a number of those were rules that we can absolutely see some value in debating further and indeed breaking. Some of them were opportunities that we thought were probably more about quality improvement opportunities, so it was about doing things differently rather than necessarily breaking a rule. So our quality improvement team that you hopefully have met today are busily working their way through those. And out of that 100 and odd number of suggestions we received, there were only 6 things that we felt we couldn't do anything with at all, and that actually we needed to keep as they were for particular reasons. So we put out to vote to the organisation, these are the rules that we think we can break, give us your top 5. So vote against the top 5, and the purpose of today is to let you know what that top 5 are. But to also say, particularly for service users, families and carers, we're doing a campaign that includes you as well, because you'll have a view on things that we do that you don't necessarily feel add value in terms of your experience with us. So it's called Your Turn to Steer. It's live at the moment. You will see little comment cards around the organisation that you can pop into a box that are orange with a steering wheel on the front. So if you've got any ideas, please do let us know. So I was going to try to do this a la Top of the Pops and wear some sort of DJ costume, but it didn't quite work out today. But I do believe that we have something that's akin to Top of the Pops to kick us off. Is that right? Do I just shout? Oh yeah, lower it down, yeah. So, in 5th place, and the winner of a Love to Shop voucher is get rid of paper pay slips, make it default that we have electronic pay slips on ESR with an option to print off paper ones if they are needed. And the person who made that suggestion was Rosie Watkins and also Jane Pugh. I believe that Rosie's here somewhere in the audience. Rosie, come on up. Okay, and in fourth place, we have allow managers to spend some of their budget to provide staff areas with free milk and coffee. This is so busy staff are able to have a cuppa on shift without having to borrow from, it says from patients, without having to borrow from others. And we, now our winner is Steve. Now Steve didn't declare his surname. We've been trying to find him. I will look to my, did we have any success? No success yet. But we do thank Steve with no surname for that. And we will be moving forward now to see how we can make a difference with regard to this issue. So then in third place, we have stop blocking internet access, open up the internet to trust staff for all websites, including YouTube, and this is particularly important around our ability to undertake research, understand practice, and great examples of work in other organisations. So we're really pleased. I don't know whether Carl Beat's in the room. No. Mandy, I understand we might be opening up to YouTube on the 5th of August, I'm told, yeah? So, hey. So we're doing something about that one within the next couple of weeks. And that was from Suzanne Whittle and also Ian Waring. Now, Ian can't be with us, but I do believe Suzanne is here. Suzanne? No. Am I going to be going shopping with your voucher? No. That's fine. No, we'll keep hold of that and we'll forward it on to Suzanne. So we've got to the top two. So at number 2, when a member of staff applies and is successful for a post in another part of the organisation, surely we could reduce the recruitment checks that candidates have to go through. And the winner for that suggestion, which was had the second highest number of votes, is Patrick Cullen. So, Patrick, do you want to come up and join us?
Have a photo.
Oh. Don't want me photo.
Don't you? Is it optional?
Yeah. Okay, so number 1. So number 1 is a really, really interesting one, and actually it's a really humbling one. And it just goes to demonstrate the caring and compassionate nature, I think, of all of the staff that work within BSMHFT. So, whilst there were variations on this suggestion, the essence of the suggestion was the same, and there were 4 individuals that made suggestions around this arena. So, probably the best way to describe this is as follows: stop wasting food. Stop discarding fresh sealed food. Food for patients that is unused and still consumable could be used for charities, to support homeless services and for staff. We are really touched by this, and it's such an obvious, logical thing, and we are delighted to absolutely support this. Now, of the 4 individuals that made this suggestion, 2, I believe, are here in the room today. So I want to say massive congratulations to Sean Jones and also Fahim Zaman. So if you'd like to come up, we can give you your certificates. Just before we go, I also wanted to just do a bit of a round of applause to the QI team and the comms team who worked really well together to get this campaign underway. Thank you.
Thank you very much, and I think it gives me pleasure to hand back to our chair, Sue, to finish off the afternoon for us. Thanks, Sue.
Well, what some brilliant ideas there, and let's look forward to particularly that last one of finding ways of making that happen. I know some of the food banks in the city are now talking about how they accept fresh produce. The food bank in my own patch had a meeting about that just yesterday. So if we are able to plug into what's happening in the food bank networks and ensure that we're handing on food that we don't need, I think that would be an absolutely brilliant. I'm not sure it's a rule that we're ditching, but it would be an absolutely brilliant statement about our values as an organisation. So nobody has told me they have any other business, and I'm going to look round just in case anybody's thought of something that they really want us to deal with this afternoon. But I'm also conscious that we're running over. So since nobody's waving at me, I am then going to close simply by reiterating the thanks from Fahim, from Rasheen, from others who've stood at the podium, to all of you, not just for being here today, but for whether you're a member of staff, a carer, a service user, a volunteer, for everything you do to support the Trust. Every fortnight, as Fahim said, we speak to new people starting at the Trust, and we say nothing that we do can be done without the people in the organisation and without the care and commitment of the people in the organisation. And so for the care and commitment you have shown in giving up an afternoon to be here with us today, and for everything you do day by day, I do want to thank you wholeheartedly, and I'll close the AGM and wish you all a safe journey home. Thank you.